Good afternoon, everyone. My name is Dr. John Paul Oliveros, and I'm from Cagayan de Oro City. I will be discussing the liver in the obese child and talk about the recent shift in nomenclature of pediatric fatty liver disease, from non-alcoholic fatty liver disease to metabolic dysfunction associated fatty liver disease. We cannot talk about fatty liver disease without talking about obesity. And obesity is excessive fat accumulation that impairs health. This usually results from imbalance in the calories we consume and the calories we expend. The latest numbers from the World Health Organization estimates around 39 million obese children less than 5 years old and around 340 million obese 5 to 19 years old worldwide. The prevalence of childhood obesity has significantly increased from 5% in the 1980s to around 10 to 30% just before the pandemic. In the Philippines, the highest prevalence of obesity is seen in the 6 to 19 years of age at around 11%. When the COVID-19 pandemic came, an increase in the prevalence of obesity in children in the United States was seen a few months after the lockdowns and restrictions. The rate of BMI increase among children doubled during the pandemic. The highest increase were seen on children who were already overweight and obese. Other countries reported similar trends. In Korea, there was around 1.26% increase in the prevalence rate. In the Philippines, we are still awaiting the latest numbers from FNRI, but we did a study last year among junior high school students in Cagayan de Oro City, showing around 2% increase in the prevalence rate of overweight and obese teenagers during the pandemic. Factors like the lack of exercise, increased screen time, and consumption of caloric-dense and sweetened beverages, along with the phenomena of eveningness, are thought to be responsible for the increase in obesity during the pandemic. This forest plot shows the relationship between COVID-19 lockdowns and risk difference in obesity in children. A statistically significant increase in the prevalence of obesity was observed from pre-pandemic to during the pandemic, with a pooled risk difference of around 2%. With the increase in the prevalence of childhood obesity comes along an increase in the disease previously seen only in adults. These diseases are associated with central obesity and insulin resistance. Cardiovascular disease, hypertension, type 2 diabetes, and hepatobiliary diseases, and even cancer are becoming more common in younger patients. Obese children are at risk to develop hepatobiliary diseases, including fatty liver, cholecystitis, cholelithiasis, and cholelithiasis. Extremely obese boys are 3 times more likely to have gallbladder stones, and in extremely obese girls, it's around 7 times. Before we go to fatty liver disease, it is important to remind you all that an obese child, just like any other child, can have any liver disease. We have to rule out the other causes of acute liver diseases like your viral hepatitis. Obesity syndromes like your Beckwith-Weidman syndrome will also have liver involvement. Also consider drug-induced liver injury in children, especially among obese adolescents taking in medications for psychologic or psychiatric disorders. It is also important to know that pediatric fatty liver is not exclusively seen among obese patients. They can also be present in genetic and metabolic disorders, intake of certain medications like steroids and psychiatric drugs, in severe acute malnutrition, alcohol abuse, especially among teenagers, and even in viral hepatitis. But we will focus more on the pediatric fatty liver disease associated with obesity in this lecture. Fatty liver disease is considered a common disease nowadays, and it is the leading cause of liver diseases in pediatrics, according to the latest textbook of Walker for pediatric gastroenterology. And there is almost a double in the incidence rate seen in the last decade. It is also now the most common indication for liver transplant among young patients in Western countries, among those less than 50 years old. The prevalence of pediatric fatty liver disease worldwide is estimated to be between 5 to 10%. And this depends on the diagnostic modality, the ethnicity, and the country where the study was performed. It is highest among Hispanics at 11%, followed by Caucasians at 7%, and Asians at 6%, in a study done in the United States. And prevalence is also higher among the obese and overweight children at around 26%. Risk factors for your pediatric alcoholic fatty liver disease include your high maternal BMI during pregnancy, low or high birth weight, and those who were not breastfed for more than 6 months, which is also basically the same risk factors for obesity. It is also associated with comorbidities like type 2 diabetes, dyslipidemia, and psychiatric disorders. Among Chinese adolescents, the prevalence was reported to be 30% among obese female teenagers, and around 80% of those were male obese patients. In the Philippines, a study done by my good friend, Dr. Sarabeth De Castro, showed that the prevalence of fatty liver is estimated to be around 30% of overweight and obese children, and is more common in males and in the school-age children. So far, we know that the number of obese children is rising, more so during the pandemic, and we know that there's a direct relationship, between the prevalence of obesity and also that of your pediatric fatty liver disease. So more or less, we expect an increase in the prevalence of pediatric fatty liver disease during the pandemic. And this is concerning because we know that pediatric fatty liver disease can progress from steatosis to steatohepatitis in 5 to 10%. And from patients who have already steatohepatitis, almost 40% will develop fibrosis and 30% will progress to cirrhosis. And 1 to 2% of these patients will develop hepatocellular carcinoma. Yes. Simple steatosis is when you have 5%, more than 5% of hepatocytes that contain macrovesicular fat. And steatohepatitis, you will have inflammatory cells in the portal areas or zone 1, often without ballooning degeneration, just as shown in picture B. And this is usually seen among pediatric patients. And in adult patients and in some pediatric patients, there's zone 3 injury. You have inflammatory cells near the hepatic venules. And typically, there's ballooning degeneration in this type. So why the difference? We are still not sure, but it may be because steatosis starts in the periportal areas, just like in the childhood type, and later becomes perivenular, as seen in the adult type with your ballooning degeneration. But still, it may be due to the fact that your pediatric non-alcoholic fatty liver disease may be a different entity, disease entity, than that of your adult type. So that we still don't know. But what we know is that for both children and adults, if injury continues, there will be periportal, portal, sinusoidal, and even bridging fibrosis as seen in this picture. And you know what's next. Why is there steatosis and why it progresses to steatohepatitis and fibrosis? Again, we're still not sure of the exact mechanism, but we know that it is complex. and that there are several factors, and the multiple hit hypothesis addresses most of the known factors behind the progression, namely your dietary intake, environmental factors, insulin resistance, adipose tissue dysfunction, changes in the gut microbiota, and genetic predisposition. So let us try to understand the hypothesis. Development of steatosis occurs when your glucose enters the Krebs cycle and is eventually converted into free fatty acids, which is absorbed by your white adipose tissue and the hepatocytes. Free fatty acids from your chylomicron particles uh, coming from your blood is taken up by your white adipose tissue wherein lipolysis occurs. And this adds up to your circulating free fatty acids. And this free fatty acids is also absorbed by your hepatocytes. And all of this will lead to accumulation of your free fatty acids and triglycerides in your hepatocytes. And this accumulation will impair mitochondrial beta oxidation and will result to inadequate disposal of your free fatty acids. And this will result to production of lipotoxic lipids and esterified cholesterol and ceramides within your liver cells. And all of these substances are toxic to the liver cells, and you will have inflammation and progression to steatohepatitis. Further hepatocellular injury happens as a result of recruitment of inflammatory cytokines. And you will also have further damage with adipokines, oxidative stress, resulting to ATP depletion. You also have lipid peroxidation and formation of aldehydes, all leading to more inflammation and injury. The gut microbiome also plays an important role in some individuals because some of these microorganisms produce lipopolysaccharides that also add to the inflammation. Activation of Kupffer cells and stellate cells in the liver lead to increased collagen deposition and net matrix formation. Thus, you will have fibrosis. And this leads to cirrhosis and then later on to hepatocellular carcinoma in some patients if the insult or injury continues. So how long will it take for a child with steatohepatitis to develop cirrhosis or carcinoma? Again, we still don't know, but there are case reports showing that there's cirrhosis developing in a child diagnosed with steatohepatitis within 2 years. For now, we know that the risk factors for cirrhosis and carcinoma depends on the severity of the fibrosis during diagnosis and also the severity of obesity. So unlike adult fatty liver disease, the course of pediatric fatty liver disease is not that well established, but there's a recent Swedish cohort study among patients diagnosed with pediatric fatty liver, and they were followed up for 20 years. And those showing steatosis had a 5.2 times higher mortality rate, and those with steatohepatitis had an 11 times higher mortality rate when they reach adulthood. And the cause of mortality were mainly from cancer, cardiovascular diseases, and liver diseases. So thus, children with fatty liver disease are not only at risk for liver complications, but also for the other complications of your obesity, just like your cardiovascular diseases, diabetes, and even cancer. So fatty liver associated with alcohol and tuberculosis was first described by Thomas Addison in 1836. And a decade later, pathologist Karl von Rokitansky published early reports on childhood fatty liver associated with excessive food consumption and visceral adiposity. And Fenton Schaffner, a pathologist, first coined the term non-alcoholic fatty liver disease to describe liver inflammation, fibrosis, and cirrhosis not associated with alcohol consumption. In 2012, the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition came up with a position paper on diagnosing NAFLD in children, and they defined NAFLD and its spectrum. In 2017, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition also came up with their own guidelines, and they define pediatric NAFLD as chronic steatosis, uh, excluding genetic disorders, infections, medications, alcohol consumption, and malnutrition. So more or less a diagnosis of exclusion. And in these guidelines, they recommend screening with your ALTs, or SGPTs in all obese children between 9 to 11 years old or overweight children with signs of metabolic syndrome. And earlier screening may also be done if there's for obesity in younger children, and if there's also a high family history of fatty liver, or if the patient has hypopituitarism. Uh, it is recommended that we advise diet and to repeat screening after 3 months, and further testing may be needed if the repeat ALTs is more than twice elevated the upper limit, and a liver biopsy may be recommended together with additional screening tests if the ALT is more than 80, because these are patients that are more prone to develop fibrosis. So you need to screen for a lot of diseases. You have to rule out a lot of diseases. And further testing should include your liver function test, screening for other complications of obesity like your diabetes. And also, you have to exclude infections, thyroid disorders, autoimmune disorders, genetic causes of chronic hepatitis as other causes for your fatty liver. Ultrasound, although it's not reliable to detect steatosis, but it may be needed to rule out anatomic abnormalities and portal hypertension. Uh, the better diagnostic imaging would be your MRI or your spectroscopy to measure hepatic fat. And liver biopsy allows us to check for histology and also to measure copper content to rule out Wilson's disease, and stain for microvesicular fat, which is usually seen in genetic or metabolic causes of your fatty liver. And also, we can assess the degree of fibrosis. We can define our patient's NAFLD into the spectrum, whether or not the patient has only simple steatosis or steatohepatitis, or already with fibrosis or cirrhosis. And the guidelines, the NASPAGAN guidelines recommends biopsy in children at risk for steatohepatitis or advanced fibrosis, like having an ALT of more than 80 units per liter, splenomegaly, and also an AST-ALT ratio of more than 1. And clinical risk factors for steatohepatitis includes your panhypopituitarism and type 2 diabetes mellitus. There are several issues for liver biopsy. One is that it is invasive, so not all parents will allow their child to be to have liver biopsy, and also there's some issue on sampling error, because steatohepatitis and fibrosis is not uniformly seen in the liver. a few months later, the American Association for the Study of Liver Diseases, or your AASLD, also came up with their own guidelines in adults and in children. And the difference with your NASPAGAN guidelines is that they don't recommend any tests as screening tests because of paucity of data, according to them. And however, they recommend still ruling out other causes of uh, fatty liver disease, no? Especially in the very young children or in the non-overweight children with fatty liver. And indications for biopsy, according to your AASLD, would include high titers of autoimmune antibodies, probably to rule out autoimmune hepatitis, when the diagnosis is unclear, and when multiple disorders are possible. And in order to establish the diagnosis of steatohepatitis, just before starting pharmacotherapy for your non-alcoholic steatohepatitis. So in both guidelines, lifestyle modification to improve diet and also to increase physical activities are the first line for management. And the NASPAGAN guidelines didn't recommend any medications, but your AASLD hints the use of vitamin E high dose, in patients with non-alcoholic steatohepatitis on biopsy. So recently, the focus on the screening and management of your NAFLD has shifted from the specialists to the primary care providers, the general practitioners, family physicians, and general pediatricians, because they are often the ones who get to see children at risk, the overweight and the obese. However, it may be difficult for these physicians to adhere to the present guidelines because uh, there are a lot of obstacles, and this leads to gaps between evidence-based guidelines and their implementation. And this is mainly due to the absence of a criteria for a positive diagnosis, because you need to rule out a lot of diseases. And there's also a lack of clarity, on the effect of coexisting liver diseases uh, together with that of your fatty liver diseases. And this leads to a lot of confusion and also excessive testing just to have a diagnosis of non-alcoholic fatty liver disease. So a lot of primary care physicians are even unaware of the risk factors for NAFLD and even the diagnosis of NAFLD and the consequences. And why do we need to actively identify children at risk? So the overweight and the obese, because one, they have fatty liver disease that will lead to fibrosis, cirrhosis, and possibly cancer. And they also are at risk for the other complications of obesity, like your cardiovascular diseases and diabetes. And then, since we don't have any approved or licensed medications for children and adults with NAFLD, we really need to do active screening, to manage NAFLD and to prevent these complications. So these patients, they need to be on diet and exercise and to do lifestyle modification, because these are the only recommended management for not for now. And we know that this is difficult, lifestyle modification, especially for kids. That is why it is also advised that we do a holistic approach. We have a team, an obesity team, dietitian, uh, fitness trainer, psychiatry, psychologist, and even the help of some of your subspecialists like your gastroenterologist, endocrinologist, and cardiologist. In some cases, and in some cases, even your bariatric surgeons. So, just in order to address the difficulties, in managing obesity in kids. And also the negative nature of the term non-alcoholic fatty liver disease, which links it to alcohol consumption, is stigmatizing. And also, the latest guidelines are also more of a diagnosis of exclusion. You have to exclude a lot of diseases. So all of these, affect uh, adherence to your management, and also even enrollment in studies, for clinical trials for your non-alcoholic fatty liver disease. So because of this, there have been several proposals to change the name NAFLD to metabolic dysfunction associated fatty liver disease since 2005. In 2020, an international expert consensus panel suggested to redefine adult fatty liver disease associated with metabolic dysregulation. And this not only included renaming uh, to metabolic dysfunction associated fatty liver disease, but they also came up with a set of guidelines which and a positive set of diagnostic criteria. And the following year, a group of pediatric obesity and pediatric fatty liver disease experts came together to address the limitations of the term non-alcoholic fatty liver disease. And their goal was to come up with a consensus, uh, changing the name to metabolic dysfunction associated fatty liver disease, and also coming up with a framework, for pediatric fatty liver disease based uh, on gender and age percentile definitions. So since pediatric fatty liver disease represents a heterogeneous group of conditions, so the panel proposed to subclassify pediatric fatty liver disease into type 1, those with an identifiable systemic disorder, and type 2, those associated with metabolic dysfunction, and type 3, those without any apparent underlying defect. However, the consensus focuses more on your type 2 or your metabolic associated liver disease. So the consensus recommends active case finding in children with obesity, type 2 diabetes, evidence of metabolic dysfunction or metabolic syndrome, chronic abnormal liver enzymes, sleep apnea, polycystic ovarian syndrome, and if fatty liver runs in the family. And to screen and detect fatty liver or steatosis, they recommend either imaging, blood biomarkers, or scoring based on these blood tests, and through biopsy. The non-invasive pediatric scores for fatty liver for now are not that reliable. Ultrasound imaging of the liver, controlled attenuation parameters of your FibroScan, and persistently elevated ALT levels to more than twice the normal upper limit, which is more than 26 units per liter for boys and more than 22 for girls, are the more reliable screening indicators for your metabolic alcoholic fatty liver disease. MRI or magnetic resonance spectroscopy are also highly accurate in estimating steatosis. However, these are expensive and not readily available. And we know that these non-invasive tests are neither sufficiently accurate or needs to be validated to be clinically useful. And for now, liver biopsy still remains to be the reference standard to confirm the diagnosis of your metabolic uh, associated fatty liver disease. So if you have a patient already with steatohepatitis and the diagnosis of your metabolic uh, dysfunction associated fatty liver disease can be made if this steatosis is seen in patients, in children with excess adiposity, meaning the child is overweight or obese or has abdominal obesity. If the child has normal weight or BMI but has metabolic dysregulation, or in patients with steatosis and having prediabetes or type 2 diabetes. So all of this, we can already classify them having as type 2 or metabolic associated fatty liver disease. Excess adiposity has been identified as a major risk factor for the development of fatty liver associated disease, fatty liver uh, disease associated with metabolic dysfunction in both children and in adults. And it is suspected in children less than 5 years old with a BMI more than twice the standard deviation above your WHO growth reference, and in children 5 to 15 years old with a BMI more than one standard deviation above the WHO growth reference. Also, a waist circumference above the 90th percentile also signifies excess adiposity. So these are your WHO BMI percentiles from birth to 1 to 19 years old. Patients with MAFLD but without obesity represents a proportion of pediatric MAFLD cases. And they are likely to be children with subtle impairment of adipose tissue function, but there's already insulin resistance and also complications. So evidence of metabolic dysregulation is defined as having at least two metabolic risk as proxy to your insulin resistance, which more or less also is the definition for your metabolic syndrome. So we have several criteria for your metabolic syndrome, but the expert panel recommends using age-specific criteria to define metabolic dysfunction. They suggested the criteria in children for younger than 10 years old be the one from your IDFIX study. And for older children, they suggest using the International Diabetes Federation criteria. So there's a newly published consensus just last year on the obesity in South and Southeast Asian countries. And in this study, we have different cutoffs for your overweight and obesity based on BMIs and waist circumferences, and different cutoffs for different countries. And for the Philippines, the waist circumference cutoff for women is 80 centimeters, and in men, it's 90 centimeters. But this is for these cutoffs are for adults. We still do not have a standard for waist circumference in children, and here in the Philippines. And the consensus really is that if we can't use waist circumference, then we can use alternates like your waist circumference height ratio to measure abdominal obesity. And in the Philippines, in a study among overweight obese adolescents with metabolic syndrome, waist circumference height ratio of more than 0.5 was correlated with metabolic syndrome in a study done by Dr. Shokua. And your MAFLD is twice as common in adolescents with type 2 diabetes. And early onset diabetes is also a strong risk factor. So the definitions for your prediabetes and type 2 diabetes are the same for both children and adults. So changing the name, metabolic dysfunction associated fatty liver disease, this aims to address the limitations and the negative implications of the previous term, NAFLD, and the MAFLD consensus propose a positive criteria, hopefully in the aid for clinicians in their clinical decision making. And the consensus emphasizes that screening is important for MAFLD, and hopefully the framework that they propose increases awareness for MAFLD, and also to help physicians and stakeholders to direct their resources at children at risk for the hepatic and cardiovascular complications of your MAFLD. these children are the overweight and the obese. And the renaming of your MAFLD also reinforces the fact that it is not just steatosis as part of a disease, but it's a standalone disease itself. So this standalone disease, your MAFLD, can exist with other diseases and even with other liver diseases. And since we know that your MAFLD is most often associated with obesity, type 2 diabetes, and other metabolic dysfunction, the best approach really for management is a multidisciplinary approach. And we know that weight loss, 7 to 10%, is able to reverse MAFLD in most pediatric patients. And also adherence to lifestyle programs results to significant reduction of inflammation and fibrosis. And exercise reduces intrahepatic fat by MRI among pediatric patients with fatty liver. But adherence to these modifications, our programs, are quite difficult, especially in children. So we need the help of a team. And lastly, this new consensus and framework hopes to enable clinicians to focus more on the children at high risk for steatohepatitis. And we know that these children will be the ones at risk for cirrhosis and hepatocellular carcinoma, along with the other complications of obesity. So since the consensus was published, a lot of articles and researchers have already used the term metabolic dysfunction associated liver disease in children. And there are even endorsements coming from a lot of pediatric societies to start using this term. So this new criteria for the diagnosis of pediatric metabolic dysfunction associated liver disease is clear, simple, compared to the previous guidelines, and the diagnosis is shifted to that of a positive diagnosis from the previously exclusion diagnosis. And then this shift also allows integration of our work as pediatricians to our adult counterparts. And it also highlights the similarities of between pediatric and adult fatty liver disease, but also the unique features of pediatric fatty liver disease. And there is already growing support for this new concept and new nomenclature, the pediatric metabolic associated fatty liver disease. And hopefully this long-awaited change will promote more awareness and help in our clinical practice, and also help in the uniformity across studies with for pediatric alcoholic fatty liver pediatric metabolic associated fatty liver disease, and also for the clinical trials for this condition. So with that, the question is, are we ready to make the change? That's the end of my lecture. Thank you for your attention. Thank you and good afternoon.